Okay, we're going to go ahead and get started. I'm going to let Dottie report on what we covered in our executive committee, and then, of course, the Office on Aging and what things we have going on right now.
Good afternoon, everyone. Angela and I somehow are the same name today, but I'm Dottie Livers, Director of the Office on Aging, and we're so glad to have you all here with us today. You're in for a real treat with our speaker. Our executive committee met for Council on Aging, and our new chair is Bill Tapp, and I think he had a conflict, so I'm not sure he'll be able to join us, so I just thought I'd give a quick report. We met today at 1 o'clock. That was the first meeting of our kind of new fiscal year, and shared a lot of great information and talked about some different advocacy things that will be going on in the region. And so we'd love to share more with you about that as far as funding that's coming forward and some legislative things that are coming up that'll be focused on, such as housing, transportation, and looking at keeping kind of scammers away from us all, as well as some other things. That group meets at 1 o'clock every second Thursday of the month before this group meets. We also have, with the Office on Aging, we have our virtual mobile meals event celebrating our 50th anniversary that will be coming up next week, September 16th. And there are many opportunities that you can get involved with that. With COVID, everything's kind of shifted gears quickly. And so Mobile Meals is going to be doing a party in the park from 10 to 1. We will be doing some online auction and also a reveal, if you will, of kind of a celebration virtually through a video of our Mobile Meals program. So we'd really love for you all to participate in that. If you'd like more information, if you have access to the internet, you can go to knoxseniors.org. You can follow us on Facebook as well. And you can call our office and get more information if you'd like to know more about that. But we'd love for you all to be involved in that next week, September 16th, 50th celebration of Mobile Meals. Our next meeting is going to be our speaker in October for Council on Aging will be October 14th. Positive Changes for Better Brain Health with Dr. Joel Anderson, who works at UT. So we're very glad about that. And then lastly, we're doing our Aging a Family Affair event this year. Again, it will be in a virtual manner or a safe distance manner. November 3rd, we will have a senior expo in the O'Connor Senior Center parking lot from 1 to 4 p.m. And then on November 4th, we will be having between 4 and 6 speakers on topics such as Medicare, planning for the future with an elder law attorney, taking care of your mental health, and some other topics as well. So we'd love for you all to join us for that. It will be free, and we will share more information about that. I'm going to turn it back over to Angela to introduce our speaker.
Awesome. Thank you, Dottie. I'd like to introduce our speaker. He's the pharmacist and owner of Fresh Pharmacy, formerly East Tennessee Discount Drugs in Lenoir City. He graduated from Samford University and got his PharmD at Mercer Southern School of Pharmacy. And that's in Georgia, I believe, right? Good old Georgia. That's where I'm from. But I would like for everyone to welcome Dr. Nowell. He is going to, I guess we're going to do drugs, as he said. So thank you so much for being here.
Oh, you're welcome. Hey, thanks for having me. I will get used to this thing here in just a second. Yeah. Okay, so get my buttons correctly and bear with me. So what you need to know about supplements and drug interactions, AKA, or otherwise known as drug-induced nutrient depletion. And one of the reasons I like to talk about this is because what we do day after day for lick and stick, it's a term we use for counting pills. The lick and stick part is antiquated because they used to lick the label, but we don't do that anymore. But the trending in medicine has been to the point where we're actually dosing people on time it's medication. And so what we have now is sort of national averages of around 15 medicines for the population over the age of 65. And so when we were in school, we were taught that if you're on 5 drugs or more, there's a 50% probability of a drug interaction. If you're on 8 drugs or more, there's a 100% interaction. New data has actually suggested that that's even higher, to the point where we're seeing reactions now with just 2, creating symptoms that we're not even expecting. And so about 100 of those have been identified in past years. So it's really kind of opened up a whole new avenue of reevaluating medicines and looking at how they interact with each other. To the point where they're starting to create new symptoms that we never expected in the first place. With that aside, and understanding that what we have, then what I did is I took a look at the top 10 drugs dispensed in the U.S. and I'll just run down the 10, because most of the patients that you deal with or you take yourself are going to be on one of these meds. More than likely, you're in about 5 of these things. There's a lot to relate to. So as you see these medications, you're going to hopefully either know somebody that's on them, or you can pay attention as we talk about the symptoms that they cause, because the medicines themselves inside the body actually create a depletion where the nutrients are actually accelerated and moved out of the system. And the problem with that is that we need the nutrients to do certain activities throughout the body. The metabolism works a certain way, and when we take things away, things don't work right. And in a case in point, if you run out of water, you got problems. If you run out of oxygen, you got problems. And this goes on and on. If you run out of zinc, if you run out of magnesium, if you run out of, you keep going and going. And so we focused on the interaction between supplements and drugs and looked at which of the top 10 medicines that are prescribed on a regular basis, what nutrients that they will accelerate out of the body. A good example that we can talk about is Lasix. I'm sure you're familiar with that drug, otherwise known as furosemide. It's the AK water pill that everybody is on, and everyone that's on it is always prescribed a prescription for potassium. It's because the loop diuretic, furosemide or Lasix, as you take it, it grabs all the potassium and dumps it out of the system. And so we run into a potassium depletion. So that's probably the prime example of what we call a drug-induced nutrient depletion. So what I'll focus on in the next little slides here is medicines that are pretty darn common, but you're probably not familiar with the depletions that are associated with it. So the first thing I want to do is we're going to look at the top 10 drugs in a quick list. So the first one is going to be Omeprazole, familiar proton pump inhibitor. We use it for the stomach. It stops the acid production and gives some relief there. Then we're going to talk about Simvastatin, or the statins in general. So that could be atorvastatin, Lipitor, Zocor, all those in that same category. They will mess with the system. Lisinopril, ACE inhibitor, we use that for blood pressure. Metformin, we use this, the Biguanide, or however you pronounce that. We use that for sugar control, really common drug. Metoprolol is a beta blocker. We use that for heart rhythm control, and we also use it for blood pressure. And a really common one is Hydrocodone and Acetaminophen for pain. And then Losartan, which is Angiotensin 2 receptor blocker, also used for blood pressure. And Hydrochlorothiazide, which is a potassium-sparing diuretic, similar to the Lasix I mentioned, but it doesn't pull the potassium as much. But it has another issue, which is kind of interesting, and we'll talk about briefly. And then Gabapentin, really popular for neuropathic pain, and Escitalopram. And in that one, any selective serotonin reuptake inhibitors that are depressed, they're going to be taking Prozac or Paxil, anything in that category was going to be in that same field there. And that's those are the 10 we're going to talk about. So what you want to do with your patients, or you, when you're looking at depletions, you're taking your medicine, you're doing what your doctor's telling you, you're doing everything right. but you go to the doctor and tells everything's looking good, but you feel just as bad as you did when you went in. So you need to pay attention to symptoms of nutrient depletion. So what we do is a little fatigue, weakness, loss of color in the skin, trouble breathing, depression, cognitive difficulties, tingling, numbness, and changes in appetite. So those are fairly common things that if anyone experiences those, one of the things you have to do is look back and go, why? Why are my fingers tingling? Why are my fingers going numb? That happened before a while ago, and now it's happening. Don't necessarily mark off these symptoms as oh, I'm getting old. There's reasons for the body to react the way it does, and so we have to identify possibly, is it associated with the nutrient depletion caused by the medicines that we're supposed to use to fix other things. So not saying not to take the medicines, but I'm just saying that we always need to keep an eye out for what we're doing. All right, sorry for this. When I designed it, it was a lot straighter. The Omeprazole, we can right off the bat here with the first one. This is what we use for the stomach's proton pump inhibitor, and it depletes magnesium. So a couple of symptoms that are really common to look for if your magnesium levels are dropping or cramping, like Charlie horses, and sleep deprivation, you can't fall asleep. So if you're on omeprazole, pay attention to those. It also dumps out calcium, and so then you have an increased probability of bone loss, osteoporosis, that kind of thing. It also affects folic acid, iron, and zinc, and when those are pulled out of the system, you can have anemia, hair loss, diarrhea, and increase in lesion development. And vitamin B12 has also caused poor absorption because of omeprazole. And if we don't have enough B12, the standard stuff we run into is anemia, fatigue, memory loss, shortness of breath, and tingling of the feet. So you sort of see how this is going. We look at the drugs, and then we look for the symptoms, and then we go, oh, okay. If I get a lot of complaining of tingling in the feet, then it's like, okay, let's go back and look at the B12 and see if we've got enough of that on board. So these aren't necessarily rules you need to stop one editor. It's just that in addition to the medicines people are taking, they may need to, especially, we'll pick on B12 here, since it's a water-soluble vitamin, it's easily depleted, but it's also just as easy to put it back in. So you can grab some B12 off the shelf, start taking it, and the problem is solved. Same thing with magnesium, calcium, iron, all that kind of stuff. And so these supplements are really easy to re-administer into the system once we identify them. But it's important that when you or you're talking to your patients is to listen to what they're saying and try to pick up on these subtle complaints that sometimes go overlooked. So Simvastatin, you've probably heard me talk about this before, but this medication, so Zocor, Lipitor, any of those things like that are classified as statins, they like to deplete the body of coenzyme Q10. And CoQ10 is really interesting because we're all born with a high level of CoQ10. And as we get older, it's less and less and less and less. A couple of studies that are kind of interesting is when you hit 0, you're dead. So that was an interesting study. Not that it's saying CoQ10 you'll live forever, but it certainly doesn't hurt to have it on board. Now, what's important about CoQ10? It's a cardiac cell modulator. So we use it to prevent congestive heart failure. So if you kind of think it's interesting, we generally have heart failure issues when we're young, and it's only something that creeps in as we age. And as the CoQ10 level drops, the CoQ10 allows the heart to beat slow and strong, and that's what you want it to do. But as we remove the CoQ10, the heart starts to beat weak, and therefore it beats faster. And when it does that, the muscle actually gets bigger and then gets congested because there's only so much space inside that chest wall. So that's an important one because here we're taking and giving Simvastatin or any kind of cholesterol-lowering drugs to prevent cardiovascular disease, cholesterol buildup for the patient. But they might not die of a heart attack, but what you've done is actually made them susceptible to having congestive heart failure. So it's very important to make sure that people that are on this medication are taking adequate amounts of CoQ10 as a supplement, because it is accelerated in loss because of this medication. So the next one is magnesium. So we learned that the CoQ10 was actually identified by manufacturers of Simvastatin. And they even created a use patent mixing CoQ10 with Simvastatin, but they've never made a product like that, which is kind of interesting. Then we learned about the magnesium deficiency connection from the manufacturers of Lipitor. They actually published it in their data. And so now we know that statins will deplete mag levels. Now, when magnesium is into muscle cramps, joint pain, Charlie horsing, feet and hands draw up, decreased sleep, irregular mood, irritability. So you can take a now you might just have a grouchy patient or something, but at the same time, the medicines they're on, because there very well may be this medicine on board and this depletion, and then he says, oh, I got restless leg syndrome or Charlie horse every time I stretch or whatever I do, then you know that the magnesium is being depleted. So supplementing back that into the system is going to alleviate it. So no reason necessarily to stop taking the medicine or necessary. Doctors do that a lot. Well, instead of taking this one, take another, take another, take another. That's not the solution. The solution is put the mag and resupplement it into the system. So next one, Lisinopril. Again, blood pressure medication. This one is referred to as the ACE inhibitor. So it affects the kidneys and it controls the pressure kidneys, and that's how it is associated with a zinc deficiency over time. So, and if we have zinc deficiencies, then we can run into anemias, hair loss, diarrhea, again, lesions, and again, loss of taste and loss of smell. That doesn't help much around here lately because loss of taste and smell is so commonly associated with COVID. So if you lost taste and smell, I would worry about COVID before I worried about lisinopril depleting your zinc levels. But these again are something to keep in mind, because if you're going to be on this, and people are on ACE inhibitors for the rest of their life, if they can tolerate it and it works for them, which it does, is quite a very effective way to lower blood pressure. If you're going to take it for a long period of time and any of these symptoms present themselves, then a simple supplementation with zinc is going to be the solution to long-term problems. Just keep that in mind. All right, now we're going to talk about metformin. We use this for diabetes. It's the mechanism by which it affects the body. It likes to deplete B12. And I know we're repeating ourselves on some things, but that's the way it is. Some drugs affect the same systems. And if you've got anybody that takes multiple drugs, if you're taking two drugs, both really got some B12 loss. So again, it's a good thing to pay attention to the entire profile. Again, B12 loss associated with symptoms such as anemia, fatigue, memory loss, shortness of breath, and tingling of the feet. It also depletes calcium, which can lead to bone loss, and it also depletes chromium, which it affects many things, but one of the particular things is for blood sugar control. And so simply get old chromium picolinate and take some supplements, problem solved. And magnesium is also depleted by metformin. Again, this is extremely common. It's dispensed. We dispense it like candy. So many people have diabetes. So many people have sugar control issues that they're on these medications, and they're going to take them for an indefinite amount of time. And so you need to really pay attention to these issues, because it'll create other problems down the road where all of a sudden the solution is not necessarily supplementation, but here, take another drug. And that just adds, fuel to the fire sometimes. So I want to talk about Metoprolol, because we use this for pressure and it's a beta blocker. It can affect the CoQ10, which we talked about, congestive heart failure. CoQ10 also helps with the mind and cognitive function, but I didn't write it on there. Interestingly enough, Metoprolol will lower the melatonin levels, which is kind of interesting. So if you've got somebody that takes a beta blocker as a blood pressure medicine for long periods of time, sleep may be an issue because you're depleting touches the hormone we use in the evening to induce sleep and keep us asleep. So that's an important way to do it. Now, at the end of this, I'm going to have all the supplements that have been listed here and the dosage recommendations, so you can take a look at it if you have any question about it, and then write the doses down if you have it. And then if you have any questions about that, you just holler at me. I'll be glad to go into more detail. All right, hydrocodone and acetaminophen, quite popular, aka Vicodin. So painkiller that used it for years, popular. It only goes after one thing, which is glutathione. Glutathione is this thing probably, but it is associated with hair loss and baldness, which is interesting. And it's mainly about detox. It enables the body's ability to filter toxins through the kidney. I'm sorry, the kidneys, not the kidneys, but. And if it's gone, it would increase the free radical damage in the blood cells. So it would lead to more damage and type activity in the entire system. So it's a very important thing to do. We use it a lot in repairing the lungs. It's a very supplement to keep on board. And people that are on long-term use of hydrocodone and acetaminophen can run into this as a depletion. So if you've got anybody that uses this on a regular basis, then glutathione supplementation is something they should consider doing, at least endpoint, where they'll take it a little bit and then back off and take it a little bit again. Can be done that way. Right. Losartan, blood pressure medicine, angiotensin 2 receptor blocker. It's just the technical. It goes after magnesium, which is cramps and sleep issues. And see, this is what you're looking for. Look for the symptoms. Listen for the symptoms. But it can affect potassium. And if it's lead to kidney failure and irregular heartbeat, poor reflexes, continuous thirst would be a symptom, and nervous disorders. So potassium is one of these key elements. That's why we give it, when I mentioned Lasix earlier in the day, because we don't want to dump out the potassium levels. And then zinc, again, is at the bottom, which is anemia, hair loss, diarrhea, and lesions. So you can start to see now when we take the drugs in the system, just do something wrong here, and start to add them. Because if the national average is 15 meds and your top 10 drugs are all different classes of medications, the probability of most people in the United States using all 10 of these drugs is quite high, which means that all 10 of these drugs are depleting all of these nutrients that we talked about. And many of these nutrients are being repeated over and over and over. So there's so many different things that could be attributing to the loss of certain nutrients. So here's Gabapentin. We use this all the time. It was designed as an anti-seizure medication, but we've never used it as an anti-seizure medication because they found out it works for neuro. It does a really good job. So what we call a Gaba analog, and it basically affects the transmission of pain through the nerve endings. And so it's very effective for neuropathic pain, a lot of diabetic foot pain, things of that nature. So it's used quite a bit. It affects calcium loss, accelerates calcium loss, which can lead to bone loss, but it also affects vitamin K. which is bleeding, and also is connected with osteoporosis. So those are a couple of things that we want to pay attention to with gabapentin. Escitalopram. We use this for depression. Mentioned it earlier. Could be Prozac, could be Paxil. In that category is what we refer to as a selective serotonin reuptake inhibitor. So in that endings, and here's my hand, and this is the nerve receptor, and then this is the neuron, and it releases serotonin into this what they call synaptic cleft, and then it reuptakes it back into the part of it, and it just keeps circulating. Well, we use these drugs to block the reuptake so that all the serotonin accumulates inside the cleft. And when that happens, you feel better about yourself, which is good. And it works quite well. Lots of people on it. The thing to keep in mind is that it can create a folic acid deficiency, which is one of the B vitamins. So it's water soluble, it's easy to lose. And with that, we have anemia, hair loss, diarrhea, side effects. We actually use high concentrations of folic acid to solve diarrhea problems, for instance. But it also decreases appetite, which has an influence on the ability to your body to absorb other nutrients. So it has a kind of twofold negative effect. And the other one is we call SSRI-induced sexual dysfunction, which the drug itself creates sort of this lack of enthusiasm or lack of libido associated with it. So you have, say, a husband and wife, and one of them is depressed, and they take the medicine and no longer depressed. Well, then the bad, because the other one's, the one that's no longer depressed is no longer interested. So we have some conflicts. There's not a way to address that other than not taking the medication. I'm not saying not to take the medication. That's a decision the doctor has to make. But what I'm going to do is a bit different. Down here below, I've given you alternative supplements to use in place of these medications if they so choose. And we talked to the doctor about this. But SAMe, which is acetylenolthionine, PHF, which is methyl tetrahydrofolate, or P5P, which is pyridoxal 5-phosphate, or 5-HT, which is 5-hydroxytryptophan. Any one of those five fits in a biochemical pathway that eventually causes the body to generate more. So instead of blocking the serotonin at the uptake, like these drugs do, you can not use those drugs and then take supplements that would actually generate more serotonin, so there would be more serotonin available for the synaptic cleft anyway. So there's a couple of different ways to go about treating people with depression without having to use that. But we're going to go with the concept people can use these medications initially for the sake of this talk. But there's always alternatives to what we could give or use and get the same kind of therapeutic outcomes that we're trying to achieve. So keep that in mind. So that would be another way of avoiding law. Now, here's my dosings. And it's hard to be so boring with this, but line, I just want to write down as we ran into the magnesium as a glycinate salt form, 200 to 800 milligrams at supper time. The calcium hydroxyapatite is the best absorbed calcium, so 500 to 1,000 a day. The MTHF is acetylopram, 5 to 10 milligrams a day. Iron, if you're going to dose somebody the iron, if you use the ferrous glycinate, it actually should bisglycinate, BIS glycinate. 36 milligrams of that a day is elemental iron. So if you have somebody with anemia problems, that's a good way to solve it. Zinc, chelated zinc, which you've heard about a lot since COVID, somewhere between 50 and 50 milligrams a day, depending on the situation. Methyl B12 sublingual dosing, otherwise referred to as M. That's the active form of vitamin B12, and so 5 to 10 milligrams a day. Just let it dissolve into the tongue. We use that to help regenerate the nerve endings on the myelin sheath on the nerve endings. So it does have a place in neuropathy as well. as well as generated use. Coenzyme Q10, somewhere between 300 and 400 milligrams a day, sufficient. Chromium glycinate to 1,000 micrograms per day. It's a very small amount. And then melatonin, 1 milligram. You don't need a lot. Interesting. If you have COVID, there's a protocol that asks for 10 milligrams at night for so many days. But if you're not, and you just want to sleep, 1 milligram is sufficient. And if you take it as some sets, you need the extended release. If you use a sublingual, it's probably the best way to do it. Put it under the tongue as a sunset. And that's the entire cascade right there at that moment, and you sleep really well. Glutathione, 500 to 3,000 milligrams a day, depends on the patient. Potassium, 40 milligrams to 100. I'm sorry, 40 to 100 milliequivalents so a day, but that would be talk to your doc before you do that one. Vitamin K can range from 0.5 to 25 a day. SAMe, pyridoxal 5-phosphate, 50 milligrams at bedtime. This is the active form of vitamin B6, which converts into tryptophan, which puts you to sleep, which converts into serotonin, which makes you feel good about yourself. Wouldn't use that. These are the selective serotonin reuptake inhibitor depression medicines. So you wouldn't want to use these on top of that because you have too much serotonin to this area. And so we would dose this with some caution. So if anybody has questions about that, holler at me and I'll walk you through what we would do there. Tryptophan, 500 to 1,000 a day, or 5-hydroxytryptophan, 150 a day. Quote by Thomas Fuller, "Health is not valued till sickness comes." So that's keeping everyone healthy by identifying these things is the best way to do it, instead of waiting until it's all falling off the cliff, so to speak. And my name is Jim. That concludes, let me get that back up there for you, the conversation. And there's my contact information. If you have any questions, holler at me now. I'd be glad to answer that you have it.
Awesome. Thank you, Dr. Nowell. I will unmute everyone. And if you have a question, feel free to ask. We also have the chat box if you would like to ask anything there. I guess I can start us out. I do have a question. So some of the supplements don't seem to look like ones you will find in obviously like a box store. Where would you get these supplements? Are they available at most pharmacies or specialty pharmacies?
Most of them are available. If you just look, there's a few in there that are a little bit oddball. Some of the active ones, like the MB12s, generally aren't sitting on the shelf at a box store. You'll find regular ones like the same, which is regular B12. And that's okay because your body can convert into methylcobalamin before it works. We use the methyl because it's already been converted, so we just skip a step. The MTHF, you'll find folic acid on a box shelf, but the MTHF is the active form. So therapeutic reasons to use the ones that are recommended here, and so you might find them out there. The glutathione, definitely, well, in a place like mine or a health food store, such as Eddie's Health Shop, over near West Town, somebody that would have these specialty type things sitting. Those are the I'm out of glutathione right now. I'm having a hard time getting it. So that's just an example of how it's used in protocols for COVID. And like quercetin and some of these things are really hard to get because there's been sort of, lots of people buying them all at once to stay off probability and the pandemic. So I hope that answers your question. Yeah, some are a little special, but the reason I told you the salt forms, like say the hydroxyapatite calcium version, is because it's the best one. You have to use the best one. The regular old calciums will eventually convert, and you don't have to use the glycinate magnesium, but you avoid a lot of the side effects. And by using the right salt forms, you convert more readily and get it into the cell to the job much more effectively. So that's why those recommendations are there. But it's not an absolute. We can work with it, whatever you have.
We got a question in the chat. I don't know if you can see it. Oxybutin.
I can't see any text.
Can you unshare your screen or stop sharing your screen? That might help with some connectivity issues, and then you might see the chat too.
Okay. I see a chat now. Oxybutin. I'd have to look on. There's oxybutin. I'll have to look that one up. Off the top of my head, I don't recall. But let me jot that down. Give me your contact info. I can look it up and give you contact and holler at you.
Also another question. Yeah, so if you want to give your contact info, yeah, he'll figure it out. Is there any supplements that can help lower cholesterol? I'm trying to decrease my level with diet, but that might not be sufficient.
Yes. We do use red yeast rice quite often. Keep in mind that red yeast rice itself is a statin medication. So it would have the same recommendations and cautions associated with statin medications. So you would want to supplement with CoQ10 and magnesium if you use red yeast rice. However, there is another drug that's not heard of that often. It's referred to as gugolipid. Just like Google, except it's used with an O. And it is a first-line agent in lowering cholesterol in India. A lot of people don't know about it. It actually is quite effective with cholesterol. So that's something to keep in mind. And I'd have to look up the dose. I don't
remember. With the 5 supplements that you recommended in place of an SSRI, were those supplements that you would take all at the same time, or should you just pick one to take if you decide that you would rather go the supplement route versus traditional medicine?
Good question. Yeah, just pick one.
Okay.
You don't need all of them. No, the 5 like at the bottom, the tryptophan and 5-hydroxytryptophan, they're like one's not as potent as the other. So they're different. Some people may respond better to one or the other. So SAMe, MTHF, they're all separate. So it'd be one of those that would be sufficient to raise the serotonin level. You wouldn't need to do multiples of that. Somebody asked about levothyroxine and why it needs to be taken on an empty stomach. It's because there is binding. It's what we refer to as chelation, and it creates an absorption problem so that your body doesn't bring it into the system and uptake it into the thyroid. So that's why it has the privilege of being dosed at first thing in the morning, away from other medications and food. I think that was the questions.
Good. You see the
And
contact info.
yeah, I'm writing it down
Okay.
for just milligrams. Iron okay prior to PM thyroid meds. Yeah, iron's okay. I would separate it by 2 hours. Someone just asked if it's okay to take iron prior to taking thyroid meds in the evening. There is some arguments about thyroid dosing in the evening, and they have valid arguments for that. But the chelating properties of iron set by 2 hours. So take it either 2 hours before, 2 hours after. And lost this.
Yeah, I stopped sharing just because there wasn't any information on there. I was hoping it might help with if anyone's experiencing some connectivity issues. If you were starting any new supplement, how long should someone give before they decide, like, maybe this supplement isn't giving me the results that I want? I want to try something, an alternative, if there is one. Is there a set time?
Yeah, we generally go 3 weeks. Yeah, about 21 days. It takes about 14 days for your body to start accumulating. We got to get those levels up. And in the third week, we're waiting to see if you're achieving your therapeutic outcome. So I would give it, 3 weeks before I gave up. And I had another question here. It says Praluent and Reuptake. It's a good question. I don't believe it's classified as a statin, but it has I'm not a fan. Let's put it that way. So we do dispense it from time to time, but I don't know. I've seen about 50% good, 50% bad as far as controlling cholesterol and not. So I'm not a huge enthusiastic proponent of those two medicines. For instance, somebody mentioned earlier they were trying to control cholesterol through diet. It's relatively easy to do the cholesterol diet in theory. In reality, it's a challenge because we're talking about the elimination of animal protein. And the problem with that is that animal protein causes the nitric oxide inside the arteries to not be released. There's like a little hole in each one, I guess is the best way to describe it. And they release nitric oxide, and then that becomes plugged. Then that makes that area sticky. And then that becomes the place where the cholesterol builds up. And by eliminating animal protein, anything that had parents, I guess, from the diet, within 2 weeks, 2 to 3 weeks, that releases all that LDLs drop, HDLs pick up, the things clear themselves out, and you'll see people drop from 300 levels down to the hundreds just by the elimination of animal protein. So it certainly can be done. The question is, in our society, it's kind of hard to do, when somebody invites you to a barbecue. So, any other questions?
If you're on the phone and you want a question, you can
press
press
only
stars.
Images, so I don't.
Yeah, if
What's that?
Anyone on the phone wants to unmute themselves, it's *6. If you are calling in on the phone and have a question. Okay. Well, if there are no more questions, thank you so much, Dr. Nowell. This was such an informative just presentation, and I hope that everyone got great info from it, what they needed to know. And if you have any questions, this recording will be online, and so you'll be able to access it. Dr. Nowell's information is there as well on the presentation. And I guess, what's your phone number real quick if anyone does have another question?
Yeah, number here is 865-988-0000, or as we like to say, 988. Ooh.
That's very memorable.
I also
okay,
have.
Well, thank you all. Oh, go ahead.
No, I was going to say I also have a new recommendation on COVID sheet that we just printed today, and so if you guys want copies of that, we'll try to figure out how to get it out there. They include prescription versions and supplement versions of how to prevent and or treat COVID, and they include the kind of ones that you hear about the news, which is ivermectin and hydroxychloroquine and things of that nature. But you know, I'm ready to use every weapon at our disposal to fight this war, and you know, safely we can some pretty positive outcomes. So if you guys are interested in that, just let me know. I know it's a little off subject, but it's still supplement related.
Definitely. You can email that to me, and if anyone would like that, feel free to call the office, and we can at 865-524-2786, and I can get that to you. But okay, well, thank you all so much. We will be here next month on October 14th at 2:30. We hope you'll join us again, and thank you so much, Dr. Nowell. It was a pleasure having you.